Okay, so thanks for the invite. Karin and I are happy to be here to talk about our recent paper in JAMA Psychiatry on looking at neuropsychiatric CMVs in a healthcare system population. And what we evaluated was their prevalence, penetrance, and then actually got feedback from the participants in the study who carried one of these CMVs about the personal utility in view of using this in population screening eventually. We don't have any conflicts of interest to disclose. So for the learning objectives today, as I said, we are going to review the prevalence of the pathogenic copy number variants that we found in the Geisinger health system population, understand the neuropsychiatric disorders or prevalence that are penetrance that are caused by these pathogenic CMVs, and then finally summarize the personal utility described by our participants. So although today we're going to focus on developmental brain disorders, in the MyCode cohort, I think it's useful to give a little bit of background information about our MyCode program overall and explain the path that led our group to actually consider looking at brain disorders in this patient population. So I'll start with a few patient stories that really are life-saving for those of you who are working in this precision health space where we're looking for causes of cancer or things like heart disease that we're hoping to prevent from happening by early interventions or more increased monitoring. And this story is from a 39-year-old woman who was in our MyCode research project and was found to have a disease-causing change in the KCNQ1 gene, which is a potassium channel gene that causes a form of arrhythmia called long QT syndrome, which can lead to sudden death. And interestingly, when looking at this woman's family history, her mother actually died suddenly in her sleep at age 26, which would be consistent with this diagnosis. Follow-up cascade testing of family members revealed that her two sons, age 9 and 13, carried the same change in the KCNQ1 gene. Both were found to have prolonged QT intervals consistent with this clinical diagnosis. And the mother and the two boys were prescribed beta blockers to prevent any adverse events. In addition, because the boys are quite active in sporting events, they were also provided with an automatic external defibrillator in case there were any things that happened during those activities. And at the bottom is just a quote from the mom saying, "I thank God for this program, that this mutation was found and I'm not bearing one of my kids," which is often the case that you hear of these types of stories when you hear about some athletes collapsing suddenly. And we have many examples of, as I mentioned, those types of pathogenic variants identified in genes that cause cancer or heart disease in our MyCode cohort. And the cohort overall began in 2007 just as a biobank. We actually have a very high consent rate from our patient population. It's around 65 to 85%. We were doing mainly in-person consenting for a long time, but just in the year or so before COVID started to switch to more online consenting, and certainly the COVID pandemic has escalated our online efforts for consenting for this study. And the uniqueness of this cohort is that we actually now have genomic data in the form of exome sequencing and genotyping arrays linked to clinical information from the electronic health record. We have more than 276,000 of our Geisinger patients consented to date for this study. Over 197,000 samples provided. We collect blood and buccal samples for DNA isolation and also serum samples. As I mentioned, we now have paired exome and genotype data with our EHR data and imaging data. And now we have, actually, we just got our last release back. So we have close to 175,000 exomes on this cohort. And to date, talking about the examples that I just provided, we've returned close to 2,300 medically actionable results to patients enrolled in this cohort. Now, although this is a research cohort, one thing I want to point out is we do clinical confirmations of anything that we identify on samples that were maintained in a CLIA laboratory so that we can give results back to the patients and they can be incorporated into their EHR. So I mentioned that the MyCode Community Health Initiative started in 2007 as basically a biobank. In 2014, we partnered with Regeneron Pharmaceutical Company, who is performing the whole exome sequencing for us as part of the study. And it was later in 2015 when really within our group, we realized that we were sitting on a lot of information that was medically important to our patient population and the participants of this study. And through focus groups, learned that these individuals really wanted their medical information relayed back to them. So we started the program in order to disclose these types of results back to participants. So currently what we're reporting back is the information from 61 genes that are, as I said, medically actionable. And this is based on information from professional groups like the American College of Medical Genetics and Genomics or the CDC. We report results limited to only likely pathogenic or pathogenic variants. At this time, we are not reporting any variants of uncertain significance, and that's in regards to these highly actionable genes. Also in regards to the CNVs that we'll talk about today. I mentioned that this just shows sort of the MyCode scorecard that shows a flowchart of the samples that we have consented down through samples provided, exome sequences, and then results that we're reporting back out to patients. And overall in this scenario, our yield for finding a medically actionable result is about 2.5% in this patient cohort. Importantly, once we identify one family member, we also identify other family members who also carry that same pathogenic variant. In our experience, that can be 4 to 5 additional members per family. So it's important to look at family history, family pedigrees, once we know the variant, to be able to identify other members who would then warrant clinical testing based on these results. So, our work in the medically actionable space that many groups are doing, that is, sort of, I think, easiest described with cancer and heart disease as broad categories, has shown that this information is useful to families. We've had many cases where we've identified cancer early, or we think been able to prevent it altogether. The same for heart diseases. And so we started to ask ourselves, as part of our other research studies, mainly around developmental brain disorders, and these are, commonly seen in pediatric and most often studied really in pediatric settings, where you see conditions like autism, intellectual disability, epilepsy. But the more we understand about these genetic etiologies that drive these brain disorders, we know that the same genetic changes can also cause adult psychiatric, neuropsychiatric disorders like schizophrenia and bipolar disorder. And so MyCode is largely a adult cohort. And so we wondered, what does it look like in our patient population as to the number of individuals who might carry pathogenic changes in genes that cause brain disorders. And so as I started with, a life-saving story related to a family who had a specific heart condition, we really look at the stories that we're hearing, and Karin will share later in the presentation, of these individuals who have brain conditions as really life-changing stories to learn this information. So this study is a 48-year-old man who was enrolled in MyCode, and through MyCode was found to have a pathogenic 22q11.2 deletion. This is one of the deletions that has been seen in individuals more frequently with autism and schizophrenia. So it is one of the common CNVs that people are doing a lot of genotype and phenotype studies on now. This individual lives with his parents still. He is single. He did graduate high school. He got a certificate in welding. He drives. He independently manages his appointments and finances. But he does have some of the typical features that we would expect when one has a 22q11.2 deletion facial appearance. In fact, he came into clinic for his disclosure session, and one of our physicians asked if it was our 22q clinic day because he recognized some of the typical facial appearances, although other more general healthcare providers may not be as in tune to those more subtle features in this that can be subtle in this particular deletion syndrome. He didn't have any history of chronic medical conditions or surgeries. He did have one psychotic episode at 35, which required hospitalization. He was put on medications and did not have a relapse of that. And his psychiatrist attempted to discontinue that medication at age 40, but he did have a recurrence of psychosis. And so he was put back on that medication. At the time we talked to him, the information that his psychotic episode was likely caused by this pathogenic 22q11.2 deletion was actually a relief to him, that it gave a medical reason to support continued treatment, that we knew that he was more liable for these types of events, and that being on this low dose antipsychotic medication was able to keep him more stable. And so his quote is at the bottom that says, "It feels good to know that there's a medical condition for my name. Medical name for my condition." So as I mentioned, these sort of broad developmental brain disorders that we're talking about include both neurodevelopmental and neuropsychiatric conditions. They're overall characterized by impairments in cognition, communication, behavior, and or motor functioning, and include disorders such as the ones, examples listed here: autism spectrum disorder, intellectual disability, epilepsy, cerebral palsy, schizophrenia, etc. And our group has published previous papers looking and exploring the significant genetic heterogeneity and variable expressivity that are observed in this set of brain disorders. And you can see that there are many different CMVs that can cause these brain disorders, as well as within a particular CMV, like the 22q11.2 deletion I just described the patient story for, that with this deletion, you can see a number of different brain disorders. So there's both significant genetic heterogeneity and variable expressivity observed in these brain conditions. And the same is true when you look at the single gene disorders that cause these developmental brain conditions, that there are now estimated at least 500 genes that we can point to as causing this group of disorders. And again, none seem to be unique to an individual clinical diagnosis. And that's even important to realize within families. So this is a pedigree that shows a deletion of chromosome 15q13.3 in a family. And you can see that when you look at different individuals who have that same CMV, they express different brain phenotypes. And our group and others are now looking into how do you explain that variable expressivity, allowing us to explore other genetic contributors, like more common forms of genetic variation that can be explored using things like polygenic scores to explain the variable expressivity of the phenotypes that we see even within individuals in the same family. So as Ryan mentioned, Karin and I both have our work at the Autism and Developmental Medicine Institute. We use this genetic-based approach to care in our clinical setting. And just to give a flavor for how frequent these genetic changes are found in clinical testing, so indication-based testing, you can see that we order genetic testing as part of routine care, including Fragile X syndrome and now exome sequencing with CMV calling. And in our experience using this clinical indication-based approach, we find a diagnostic yield or are able to provide a clinical answer to these families in about 40 to 50% of our patients who warrant genetic testing. And we have a fairly large practice with more than 5,000 encounters per year and continue to get a large number of referrals. And so we find this type of testing is really critical in this patient population to end the diagnostic odyssey, provide the families with an answer. And a lot of our research is now focusing on how do you provide tailored care based on this information going forward. And why is that important in this setting? Well, here are 3 children who have a clinical behavioral diagnosis of autism, but if you now layer on their genetic etiologies, we know that Fragile X syndrome is very distinct from an individual with a 22q11.2 deletion, as it is very distinct from a child with Angelman syndrome. And so there's no reason to expect that the treatments or therapies that we might pursue in these individuals is the same. There may be some overlap, but we really need to treat these based on their etiological diagnosis instead of their behavioral or clinical diagnoses. In addition, and obvious to geneticists is that knowing a genetic etiology allows genetic counseling to provide more accurate recurrence risks for the family, which is always important. And as I said, leading to better targeted medical monitoring. So as I mentioned, to date, most of these studies of these neurodevelopmental or neuropsychiatric disorders have investigated large clinical cohorts like the one I just described at our Autism Institute, or research cohorts that are very focused on a particular categorical diagnosis like intellectual disability or autism or schizophrenia, et cetera. And so therefore, these types of studies are really biased towards ascertainment of the most severe phenotypic consequences of these types of genomic variants. And we need more data to understand the clinical consequences in unselected populations in order to really understand the broader phenotypes that these individuals may be exhibiting. And so that was one of the main points of the study that we embarked on, was to, in a large healthcare population, as I described, we used the MyCode cohort for this study. We wanted to look at how frequent pathogenic copy number variants are in the system, evaluate the penetrance in these individuals in an unselected healthcare cohort, and then evaluate the personal utility of learning this information. So could we attribute a personal utility similar to that of learning that you might be at risk for cancer, or learning that you're at risk, higher risk for a heart attack, and how do patients view that information? So I'm going to start by going over our data on the prevalence of pathogenic CMVs, and then Karin is going to take over when we start evaluating penetrance and personal utility. So at the time of that the JAMA Psychiatry paper was published, we had used about 900,000 of our patient participants' data to look for a set of copy number variants. We called the copy number variants off of our exome data, and then used the genotyping arrays as confirmation, as well as I mentioned that we did clinical confirmation for any results that went back for clinical reporting to participants. This is the largest health system-based population that combines genomic data with these EHR-derived phenotypes, which really affords us to do this study. And we took a conservative approach to the set of CMVs that we examined. So we looked at the frequency of 31 pathogenic recurrent CMVs. So these are copy number variants mediated by segmental duplications, so that the unique region of each of these is the same between individuals. And we identified these pathogenic CMVs using evidence-based criteria, including that put forth as part of the ClinGen, the NIH-funded clinical genome resource, or ClinGen dosage sensitivity map. And so many of these, are larger CMVs, greater than 250 kilobases. So of the just over 90,000 individuals, we found 708, or 0.8%, who have one of these pathogenic CMVs. And importantly, only about 6% had a previously known genetic diagnosis in their EHR. So the majority of these individuals did not know that they carried one of these pathogenic CMVs that in routine clinical testing would be reported out as an abnormal finding. When we delved a little deeper into the cohort who knew their genetic diagnosis, we found that those individuals tended to be younger, so a mean age of 20.33 years compared to 50.04 years for all CMV positive individuals that were identified in our study, meaning that a lot of the younger individuals may have been afforded this type of testing, which clearly isn't yet part of routine clinical care in older adults who may exhibit similar phenotypes that eventually, and we think now, should warrant this type of testing. So this table just compares our results to those of a few other population-based population-based studies that looked at CMVs and a similar overlapping set of CMVs, but not identical, but many of the same are overlapped. And you can see that in both the Discover cohort, which is a subset of the MyCode cohort, as well as the Decode group, which is the Icelandic population, the EggCut, which is the Estonia group, and the UK Biobank, we're all hovering around the 1% range in this broader cumulative CMV list for having individuals who carry these CMVs that are known to cause brain disorders. This slide just shows within our deletions, what were the most common. So just highlighting the 5 most common deletions that we identified, including deletions of 1Q21, 15Q13.3, the distal breakpoint 4 to 5 region, 16P13.11, 16P11.2, which many are familiar from early reports associated with autism and other brain disorders, and 17P12. And likewise for our most common duplications, again, 1Q21, the same region, but the reciprocal duplication is one of our more common findings. The 16P11.2 reciprocal duplication to the deletion, 17P12, 17Q12, and then the reciprocal duplication to the 22Q11.2 deletion. So overall, and just really to compare, if we're thinking about population screening for this class of diseases, what do the brain disorders compare to other diseases that we are already screening for? And if you look at prevalence alone and estimate that these, a conservative estimate is 0.8%, because as I said, we only looked at 31 known recurrent CMVs. You can see other diseases compared here, including familial hypercholesterolemia, which is about 0.4 to 0.5%, Lynch syndrome, a familial cancer syndrome in about 0.2%, and hypertrophic cardiomyopathies in about 0.2%. So now I'm going to switch over and Karin is going to take over to talk about penetrance. Good afternoon, everybody. So after establishing some comparative prevalence estimates of CMVs versus other disorders that are commonly included in population screening models, we wanted to next ask this question of all of the individuals with a given genotype, how many have phenotypic features that would be consistent with CMVs? And that's the basic definition of penetrant. So how penetrant are these pathogenic CMVs in this hospital-based population? So to do this, we looked at all of the individuals with one of the 31 identified CMVs, and we pulled EHR data, and any individual who had an ICD-9 or 10 code that would be consistent with neuropsych or neurodevelopmental disorder, or a congenital malformation that would be consistent with the CMV. And we actually did this analysis in 2 ways. So this is a very sort of collective approach, right? We aren't saying who has autism, who has depression, who has schizophrenia. We're lumping these all together using the DVD approach. But because depression and anxiety are also very common in the general population, we actually ran this analysis both with these codes and without. So when depression and anxiety codes were included, we found that 66.4% of CMV positive individuals had one of these NPD or congenital malformation codes. So this resulted in an odds ratio of 2.21. When we excluded these common depression and anxiety codes, that number dropped to 28.8% of CMV positive individuals, with still a significant odds ratio at 1.53. Looking a little more deeply into the congenital malformation codes specifically, those were seen to be enriched in CMV positive individuals' EHRs, specifically with an odds ratio of 2.00. And the subgroups within, so really within specific organ systems were also looked at, and cleft lip and palate was observed as the highest in the CMV positive group, with 9.84 higher odds of being present. The remaining congenital malformation groups were generally about 2 to 3-fold higher as well. Next, we wanted to ask the same question, but focus more on the 9 deletions that we had prioritized for disclosure to my code participants. So overall, there were 280 individuals who had one of these 9 prioritized deletions. And at the time of this publication, there were 141 who were eligible to receive the results. So of those 141, you can see in this table from the paper, the 9 deletions on the left, the total number of participants who had each of these CNVs, the breakdown by sex, and their mean age at disclosure in years. And on the right, you'll see a broad range of distinct clinical diagnoses that were observed in these individuals, with depressive disorders and anxiety disorders generally being the most common, but really a smattering of additional psychiatric disorders such as bipolar or mood disorders, psychosis, schizophrenia, obsessive compulsive disorder. There were many people with seizure disorders, which would be consistent with their CNVs, and learning disorders, intellectual disability, and more rarely autism spectrum disorder. Remember that this is simply what is documented in the participants' EHRs. So it's not necessarily the truth of how they would actually be described if they were formally assessed. When we repeat the analysis of really focusing only on our 9 prioritized CNVs, so this is again of the total 208 individuals with one of these 9 CNVs, 77.1% of these individuals had evidence of MPD or congenital malformation in their EHR when depression and anxiety are included. So it was, if you will, more penetrant in this subset of individuals. And when depression and anxiety are excluded, nearly 50% had evidence of penetrance. But we really feel that these penetrance estimates are likely to be underestimates. And the reason for that is because of our experience talking to participants when we returned these results. It was extremely common for participants after receiving results and talking with a genetic counselor to share additional neuropsych or neurodevelopmental history that was not documented in the EHR. So this figure in the dark gray is showing the NPD diagnoses that were present in the electronic health record. And the light gray shows the additional history that was shared by the participant. So you'll notice depression and anxiety, again, are the most common and tend to, most of the psychiatric disorders tended to be well documented in the EHR. But of note, the intellectual disability and learning disorders were relatively lacking in documentation in the EHR. So it was extremely common for participants to tell us of histories of major struggles with their early educational experiences, needing to have an IEP or to be in special education classes, not being able to finish school because of learning disorders, and really sharing that learning disorder impacts them throughout the rest of their life as well. So they would also share stories about how this would impact their employability or their ability to maintain employment, or social abilities with others as well. So again, comparing the penetrance of this collective group of CNVs to other disorders that are routinely included in population screening, they compare pretty well. So 30, 35 on the low end of a penetrance estimate, up to at least 70%. Compare that to familial hypercholesterolemia, which has a 30 to 50% risk for a coronary event. Lynch syndrome, which confers 52 to 82% lifetime colorectal cancer risk. And BRCA1 and 2, which carries a 38 to 87% lifetime breast cancer risk. So now that we have a sense of how these disorders compare in terms of numbers, prevalence and penetrance, we wanted to explore how individuals would perceive receiving this information. So is this harmful to them? Is it helpful to them? Do they value the information? And we wanted to approach this really in a very sort of open-ended manner. So just to quickly review, we disclosed a select 9 CNVs. These were all deletions shown there on the right. These CNVs were, again, defined as recurrent pathogenic CNVs that are mediated by segmental duplications. Their clinical phenotypes had to include neuropsychiatric or neurodevelopmental disorders. And we further prioritized these CNVs based on the prevalence in our cohort and also considered the type of non-NPD medical implications. So, if there are risks for tumors, for heart disease, for renal abnormalities, things like that that would warrant additional screening, then that elevated those particular CNVs in our mind as more relevant and more appropriate to be returning at this juncture. We had additional eligibility requirements. So at the beginning of our experience with this, we were only returning CNVs to participants who had NPD or congenital malformation documented in their EHR. So we wanted to start with that group of individuals first. And we only returned results to adults, so they had to be 18 years or older. And then there are additional MyCode requirements. So we needed to ensure that they had adequate consent. So the most up-to-date consent on file, which allows for return of results, and adequate sample remaining so that we could do orthogonal clinical confirmation. So 141 individuals received results. About 2/3 were female, 1/3 male. The average age was 48.5 years, with a range of 21 at the youngest to 87 at the oldest. And this gives, this is a flow diagram of our overall disclosure process. So after we received the clinical lab report confirming our research finding, we actually reach out to the patient's primary care provider to notify them that this result has been identified, invite them to contact us to let us know of any relevant information or ask any questions. And we're really, we're not giving the result to them to pass on to their patient. We're welcoming them into the process if they want to become involved. And we're letting them know we plan to reach out to this patient. After a week, we then begin notifying participants. We first do this with a letter, letting them know that we've identified something that is clinically relevant and inviting them to contact us. If we don't receive contact from the participant, we make 3 phone call attempts, and leaving messages, and then really that brings us down to the different disclosure outcomes that we can get at the end of this process. So this was all pre-COVID. So at this time we didn't have telehealth visits. We are doing telehealth visits now. But our ideal is the in-person genetic counseling session. And that was our most common outcome. So 72 individuals responded to us and elected to have an in-person genetic counseling session. 21 individuals opted for a full telephone genetic counseling session. And 28 made contact with us, had a more brief discussion about what the findings were, and either were lost to follow up or really just decided that they had enough information and they would prefer to receive a packet of educational materials from us and call us if they needed us. There were 18 individuals who did not contact us at all, and those all received mailed information via certified mail. And 2 were deceased, and their information was returned to next of kin. So after meeting with the genetic counselor, then the clinical follow-up is dependent on the patient. So The CNV result and the genetic counseling session are always documented in the patient's EHR. All patients receive educational and support resources. If referrals are discussed or necessary, we make sure we reach out to the primary care physician to discuss those, and we can place them as well. Family testing or cascade testing is initiated as needed. And often these individuals are really interested in additional research opportunities. So at the time of beginning this study, we had 3 genetic counselors who were experienced in developmental disorders who were returning these results. And we wanted to have a lot of flexibility in our sessions to really let the participants ask the questions they needed to ask. But we also wanted to promote some consistency across our team and ensure that we were all sort of focusing on at least some similar domains for collecting participants' responses. So this image is our disclosure session outline. And we really treated this as a very flexible genetic counseling session, just like most are. We didn't treat this as an interview per se, but we did try to assess these 4 domains for psychosocial assessment. One is the participant's consent experience. So what do they even remember about my code when they may have signed up, a few years ago? And does receiving this type of information seem totally in line or out of line with what they believe my code to be? What were their immediate reactions? How do they feel? What do they think about this information? And how does their result impact their medical beliefs and their self-image? And then finally, what are their thoughts about communicating their results, both with their healthcare providers and with their family members? And this ended up being a really great decision because we were able to use this outline as a data collection resource. So after every genetic counseling session, the genetic counselors would write sort of a journal entry, if you will, or we would write our reflections or notes of how did the session go? What did people say? What were their responses? Putting in our recollections of quotes as available. And this became a data set for qualitative analysis. So the data that we included in the JAMA Psychiatry paper pertaining to participant experiences actually included 2 data sets that we analyzed independently. One was those GC written notes that I just described, and we had 38 of those. We also had audio recorded and then transcribed sessions from 14 individuals. So participants could provide written consent for this. And interestingly, there were very few people who declined this. They were extremely comfortable having their sessions recorded. We now have, so for this publication, we had 14 available transcripts. So these 2 data sets were assessed independently. We used a grounded theory approach with 2 independent coders to generate codes for themes and subthemes. All transcripts and notes were discussed to reach consensus and for the developmental final code books. We also discussed our codes with the general GC team as sort of a validation of this is what we're seeing. Is there anything else from the experience for your GC notes that wasn't coming through? Just some demographics of our data sets. So for our GC disclosure notes, there were 38 total. The mean age for those participants was 53.5 years. And the sex proportions were pretty consistent with our general 141 participants. Of our transcribed recordings, very similar as well. The mean age was just slightly lower at 49. And the number of individuals per clinical diagnosis is here at the bottom. So depression and anxiety, again, are highest, followed by a sort of random psychiatric disorders, like kind of one-offs, bipolar disorder, epilepsy, intellectual disability, autism, and then other medical history was not uncommon. Other medical history that's consistent with the CMV, I should say. So from this subset of data as well, here's just the breakdown of individuals by CMV. So from this comes from the 38 GC notes, written notes. So our most common was 16p13.11, which was also our most common out of the 9 prioritized CMVs, followed by 1q2 1.1 deletion and 16p11.2. So I mentioned that we analyzed these 2 data sets independently, but we were very pleased to see actually that the major themes that came out of those 2 data sets were very consistent across the 2 data sets. And so this is really a table showing those major themes. First of all, participants really were very open about discussing their NPD history. And it was incredibly common for them to discuss history, especially learning problems and interpersonal difficulties that were not recorded in their EHR, either because they were older adults and this is just not something that their physicians are thinking about. Their physicians might notice, but they aren't making an assessment and a diagnosis pertaining to that. Most participants also had kind of a previous explanation in their personal story about why they had that history, that NPD history. And most of the time they attributed that history to social circumstances. So things like trauma or moving or family disruption, like their parents divorcing. They very often expressed that this genetic diagnosis fit or made sense with their lived experience. So they knew these things about themselves, and now they had a reason why. And it kind of was pulling it together and helping them make sense of themselves and their family history. And this tended to reassure them that this wasn't actually their fault. It sometimes removed guilt. They typically stated that they felt that their sense of self or how they feel about themselves stayed the same or actually improved. Most individuals expressed both positive and negative emotions during the course of a session. Positive emotions outweighed negative emotions when we actually counted the number of codes. And importantly, those negative emotions were not about the genetic result. Those really were coming out when people were talking about their history and remembering things that had been challenging and hard for them. So participants are feeling that or believing that this information is valuable. And they also really made several indications of resilience, that they'd been resilient throughout their life and that they could handle this and they would continue to be resilient. So overall, our findings really indicate that participants describe receiving these results as personally valuable. Their positive responses are outweighing negative, and those negative emotions are about recounting their past experience, not about receiving this information. They actively incorporated their results into their personal narrative. And interestingly, learning and understanding this information was sort of kind of a family event or a group, what we would call group nature, which isn't unusual for genetic disorders. But really, I think what we observed is it helped people make sense of their mother's psychiatric history or their child's learning disabilities. But there was also an element of support provision, because sometimes people would bring their parents with them to help, to have somebody else listen to this information and help them understand it as well. And what we really found was participants were very open to discussing their history with us. And they typically indicated that they plan to share their result with their family and talk to their healthcare providers about it. So again, pointing to, or a point of comparison here, we tend to think about the clinical utility of information. What would we do medically to help a patient? This type of experience really tells us that finding out that you could have a medical explanation for NPD can be personally useful. So this is just the definition that I like to use for personal utility. That this information would reasonably be used for decisions, actions, or self-understandings, which are personal in nature. And that's exactly what our findings showed. But that's not all it indicates.
Sorry to interrupt. We have 5 more minutes for you.
Okay, I'm sorry, I'm wrapping up. So I just want to stress too that it doesn't end at personal utility. This is also an opportunity to inform educational and NPD support needs, promote health decisions and treatment access, screen for those non-NPD health risks that we talked about, and cascade testing for other family members. So moving forward, just a couple more slides. This is kind of our main takeaways, that these CNVs are prevalent and penetrant to degrees that are consistent with other populations screening disorders, and that participants value receiving this information and describe the experience of learning this as important and valuable. So moving on, we are continuing to build this program. MyCode continues to add additional participants. Additional exomes are being released all the time. And we've now expanded our program to disclose results to participants regardless of their EHR documentation. And even individuals who don't have NPD documented in the EHR are telling us the same comfort, the same importance and value of receiving this information. We also have some additional studies planned with longitudinal follow-ups, so 6-month surveys and interviews, and some family-based studies planned to assess the relational and support factors that might influence patient behaviors. Okay, so just ending with huge acknowledgements for all of our collaborators, and particularly the MyCode participants who make this work possible. Thank you very much.
Okay, so great. That was wonderful. I guess we can open up to questions if anybody has any. Okay, well
hi. Thanks for the presentation. I have many questions. So do you have any information about if these CMVs were inherited or de novo germline variants? Or were there any sequence the patients who were at the genetic counseling, the parents of the patients?
Yes, I don't have the numbers off the top of my head, but and in part because we weren't able to systematically just test that for every one of the participants. Many of our participants are older, so their parents aren't necessarily living. And Medicare won't necessarily cover testing for this either. So sometimes we ran into coverage barriers because at the point of cascade testing, we're now in the clinical domain. And so it depends a little bit on each participant's family member's situation. But we certainly identified many family members who tested positive, and including parents.
Yeah, so there are many common germline copy number variants present in the human genome, just for example, based on NOMAD. Have you filtered these variants out, or what did you do with this problem?
Yeah, I mean, we only looked at a set of 31 CNVs that are known pathogenic copy number variants that are mediated by SEG-DUP. So for this study, we filtered all of the common copy number variants like you would see in NOMAD were filtered out for the analysis.
And can I ask what was the kind of cutoff for common variants? Because neuropsychiatric disorders are, I don't know how frequent, but they are not so uncommon.
We didn't use a frequency cutoff.
Right.
We used more inclusion criteria based on these are known pathogenic.
Oh, okay,
variants.
okay, got it,
And
thanks.
yeah, and really, if we had used a frequency cutoff, we maybe would have filtered out known pathogenics because our data itself shows that there's adults in the general population who have these. So, yeah.
Yeah, we sort of use the opposite approach is what you're asking about.
Yes,
So
yes, so
we define the
it makes,
CMVs
it makes
first.
sense for your data set. Okay,
Yep.
thanks. Yeah, so can you tell a little bit about the data set? So this whole, what is it called, my code cohort, what was the patient's main reason to be included in this cohort? I'm just looking for if there is a bias, like they already suspected that something is wrong with them, and does they applied or?
So the MyCode cohort is an unselected insofar as we have consenters who are just situated at various clinics across our system. So there isn't any particular emphasis like we're going to focus on cancer clinics or we're going to put people in the cardiac clinics. It really is sort of trying to get the best representation of the patients who are coming. So
Yeah.
many of them are coming for some level of care. Others are just coming for a well patient visit.
Thanks. And my final question is about the response of the patients to the results. So I think isn't it like a bit of a confirmation bias that they are happy about the results or not, yeah, kind of happy. And I don't know how you can filter that out. And also I'm really interested in do you have any literature data or your own data about the long-term effects of actually getting a right diagnosis, and also so it's can be a little bit, what is it called? I don't know the English word for it. So if it's actually making the patient's life better or happier.
Yeah. So we definitely need some longitudinal data to actually see how is their initial response maintained, or if it is maintained, or if it changes. And we certainly need to address the question of clinical utility. So I think that's a big reason why we need to engage with the physicians more as well to know what's their experience? Does their patient come to them? And do they have what they need to address their questions? So you're right that our data is really at one point in time, and there's certainly some bias because we have the data of the people who came to us, who wanted to talk to us, right? And they're right there with us in the room. So people are generally polite and want to kind of be nice and stuff like that. So that's a legitimate comment for sure. I think what is a good complement to this approach is that we also have surveys that we give people right after they receive their results and at 6 months. And we're still kind of, amassing, we're in data collection for that phase. But preliminarily, what we're seeing is even people who don't meet with us, they only talk to us briefly over the phone, or they get their results by mail, they're sometimes sending in their surveys. And we're not seeing a big difference between the people who respond to us and come in for a visit versus those that don't. And measures like decision regret and their feelings about their results are consistent over time. So they are not reporting decision regret and things like that. So that's also, I think, reassuring.
Thanks. Thank you.
Yeah, thanks.
Excuse me. I have a question. First, thank you very much for the presentation. It's very interesting. And since I'm not a scientist, so maybe my question is more general, or it's just from my interest. For my understand, this research is like you guys found some of the people, they have the problem with their CMV, and then find how many people has what kind of problem. My question is there any numbers that when we find the clinical sorry for my language. I just think if we already diagnose some of the people has the problem, how many of them has the problem with their CMV?
Okay.
Do you mean how many people who have brain disorders have those brain disorders because of one of these CMVs?
Yes.
So what, about 10, 15%?
Yeah, I think the best estimates are around 10 to 15% that we know now.
Okay, so that means most of the brain disorder people, we cannot diagnose them with the CMV problems.
Well, those estimates also come generally from children who are being seen for like late walking and talking or learning problems. So again, more severe. And so it may be that if we actually were doing a better job of offering testing to adults with different manifestations, like the psychiatric manifestations, we might see that number is different or higher.
Yeah, and you also have to remember that the CMVs are only one mechanism for a genetic cause. So there could be single gene disorders. We now know there's contributions from more common variation. So what we hope is that we start to fill out that piece of the pie, and that we'll learn more and more and be able to explain more via these genetic etiologies.
Okay, thank you.
Mm-hmm.
I have one question. I was just wondering that which pipeline or what software did you use to do the CMV calling by use the whole exome sequence data? And right now in our team, we actually have used the CMV kit and also use GATK GCMV to do the CMV calling. So could you talk a little bit more about which software did you use or which strategy you have used for the whole exome sequence data?
Yeah, so we actually used, through our collaboration with Regeneron, a program that they developed and is published. The acronym is CLAMS. I was just trying to look, I never remember what the full wording is for it, but it's CLAMMS. Copy number alignment was something. But sorry that I'm not remembering it right now. But we solely used that copy number pipeline. And, as I said, the ones we reported in this paper are all 250 KB or above. So requiring probably a less robust, pipeline for using multiple algorithms to call and compare. But at that resolution, all of the copy number variants we called were confirmed by doing a separate orthogonal clinical test. And we also were able to see on the genotyping arrays as well, using PennCMV, that those copy number alterations were present.